Hi guys, this is Dr. Lisa Shiver with part 4 of the lower GI alterations lecture. In this section we're going to look at disorders that happen at the end of the line, starting with hemorrhoids. Hemorrhoids are dilated hemorrhoidal veins and can be found internally on the inside where you can't see them. They can be external where they are obvious, or thrombosed. Thrombosed hemorrhoids can occur on the inside or outside, but when we have thrombosed, they are engorged with blood, and often there is a clot that is formed on the inside. They're very, very painful. Signs and symptoms can range from anything as far as asymptomatic to bleeding with bowel movement and pain. Stressors are what puts you at risk for hemorrhoid formation: pregnancy, constipation or straining, doing heavy lifting, and also hypertension. To treat hemorrhoids, pretty simple. Increase the fiber and the fluids for most patients and they will resolve, because that's going to prevent the constipation and straining. Stool softeners may be introduced to facilitate defecation. And then for some patients, they need some Anusol or Preparation H, and that will help decrease size, pain, and help resolve the hemorrhoids. When hemorrhoids are pretty severe, we may have to do what's called a hemorrhoidectomy, or removal of the hemorrhoid. Again, that would be indicated if they were prolapse or causing prolapse of the rectum, there was increased pain, or they were fairly large in size. Nursing care, post-op hemorrhoidectomy, narcotics. Give your patient narcotics. It's very painful. We also want the patient doing what's called a sitz bath. They'll do a warm sitz bath 3 times a day, usually for a couple days post-op. And what a sitz bath is, and I've got a picture here on the right side, there's a basin there that we can put down inside the toilet. The patient would sit on top of this basin, and then we would run this warm fluid over the perineum. Sitz baths are common after females have vaginal deliveries, or if they have an episiotomy, but they also are very effective with hemorrhoids as well. What it does is it increases the blood flow to the area and helps promote healing, and it makes the patient a little more comfortable, so they might actually opt to do it more than 3 times a day. With a hemorrhoidectomy, the patient may return with packing present there at the site, and that can be kind of complicated, how to take care of that area yet not get the dressing contaminated with stool. Patient should be prescribed some stool softener as well to help facilitate bowel movements. Second disorder we're going to look at is an anal fissure. And this isn't the best picture, but essentially what it is a tear or a crack or an ulcer in the anal wall. It's usually due to trauma, like constipation. If the stool was hard to pass, it could tear the rectum. Could be secondary to infection or some other inflammatory issue going on. But the major signs and symptoms, we're going to see pain. They may complain of spasms, bleeding. And of course, if all that's going to happen, well, then I'm not going to want to go to the restroom, so it can lead to further constipation, which then in turn could lead to a worsening of a fissure. Treatment for anal fissures, we want to make sure the patient's on stool softeners of some kind. Colace is usually a good one to go to. We can use warm sitz baths on the bottom there, and that'll help with the healing and also their comfort. And Anusol suppositories are pretty beneficial. Those are pretty self-limiting and usually will repair themselves if we can prevent constipation. Another disorder is the anorectal abscess. This is where we have a collection of pus that's secondary to either an anal fissure that has gotten abscessed. It could be trauma related. It may be related to irritable bowel disease. Signs and symptoms: local pain. We're going to see some swelling, foul-smelling drainage. It's going to be from the abscess itself, tenderness and fever. Of course, with all this going on, the patient, again, is going to be at risk for constipation. To treat an Anorectal abscess, we do, or the doctor, the surgeon, does what's called an IND. It stands for incision and drainage. So they'll go in and surgically incise the abscess, drain the pus, and frequently they'll have to put packing in that as well. And the purpose of the packing is to keep that abscess from reforming. If we leave the packing in there and just gradually remove a little bit of packing each day, then it allows for the wound to heal from the inside out, so more pus doesn't accumulate in that area. Sitz baths can also be very beneficial for these patients. Next, let's look at an anal fistula. We mentioned fistulas earlier when we were talking about Crohn's disease, and this diagram has a great illustration of what a fistula is. If you notice there on the right, we have the darkened area, or that abnormal tunneling that has developed. This is secondary to an abscess. This abscess tried to take care of itself, and it developed this abnormal tract. If you notice, the fistula exits at a different point than the rectum. So what has happened here is we're going to start to see stool pass through the rectum, but also we're going to have an abnormal little tunneling there to the side where stool will also pass. With an anal fistula, when stool gets down into that area, it's going to cause an infection and very well could lead to an anorectal abscess. Signs and symptoms with a fistula, we're going to have blood-stained or purulent discharge and or stool leaking from that fistula. And the fix for this is fistula correction, and that's a surgical procedure. They'll go in and excise or close that fistula. The treatment is going to be the same for someone who had a hemorrhoidectomy, so sitz baths and things of that nature. Please note that these fistulas may go to an area that we don't expect. This fistula comes to the outside, so it's going to exit right there by the anus. With some fistulas, the abnormal tunneling may lead into the bladder, or for females, you could see an abnormal fistula going from the rectum to maybe the vagina. So fistulas are not always predictable where they go, but if you have a patient that has maybe recurring vaginal infections or recurring bladder infections with E. coli present, well then we may suspect that there's a fistula or that abnormal tract that is formed between the two. And our last disorder we're going to look at is called a pilonidal sinus, or a pilonidal cyst. It's also known as a nest of hair. And I've got a picture there over on the right hand side. This is a small congenital tract under the skin at the base of the spine that patients are born with. Not everybody has this, but this little cyst that's here, it's got hair, it's got skin inside of it, skin cells inside, and when there's movement and moisture, sometimes they do abscess. When they do abscess, they're going to have swelling and pain, or when there's infection present, there's going to be swelling and pain at this cyst. To treat them, we do incision and drainage, so that's a surgical procedure where we incise or cut open and then drain the cyst. We may use hot or moist applications. The patient may have packing there until that resolves. We want to keep our patient in prone or lateral position for obvious purposes there, and have them avoid straining because that can be painful as well. But it's just this little congenital tract. Not everybody has it, but it's at the base of the skin that sometimes can develop an abscess. And the reason it's called nest of hair is because there is hair inside of it. And that concludes this section of the GI lecture.